further ado, I'd like to introduce Dr. Betty Maloney. She'll be talking about Lyme disease testing.
Well, oh, I'm high tech? Isn't that great? Oh. And is this loud enough for everyone? They're shaking their heads, yes.
Wonderful.
Tonight we're going to talk about testing, and feel free to interrupt me. I think that I can keep my train of thought sufficiently during questions. And I think for you, if you ask the question on the spot, you're more likely to be able to follow the conversation going forward. If you wait till the end, I think it's much harder. And I really want to focus on ELISAs and Western blots, because those are the tests that they're the ones that are ordered the most. They are definitely the ones that you need to have done if your doctor wants to report you as a case of Lyme disease. And they're also actually the tests that are our greatest enemies, because they keep people from being diagnosed. And so if we can all understand the tests, then we can kind of intelligently work our way around this obstacle. Now, why does everyone want a test? Because believe me, even after I tell people how lousy the tests are, people come up and say, okay, who will order me a test? And so everyone wants it. I think that patients want tests because they've been misdiagnosed along the way, and I think maybe even mistreated at times. And so their confidence and trust in physicians is not as high as it normally might be. But physicians want that test too. And one of the reasons is because Lyme has so many flavors. The physicians who are trained in Lyme have a really hard time getting a handle on all the symptoms and sorting through them. They're very fearful that they're going to miss a case of lupus and call it Lyme or vice versa. And so they really want a test. The other thing that a test does for a physician is it is a shield. A positive test result, and no one can talk behind my back. No one's going to criticize my diagnosis if I've got that positive result. And so both groups want the test. There's just one problem, is that everyone has this trust of technology. Technology is great, always saves us. And unfortunately, in Lyme disease, the tests stink. Very blunt assessment of testing. Now, the way medicine is supposed to work is you come into your doctor with a problem, and maybe you start out and say, I hurt, and that's a common complaint. Well, right away, our wheels are spinning. Okay, where do they hurt? We have a million questions, and there's a lot of possibilities for just the simple, I hurt. And so we take what's called a history. We're asking you all sorts of questions, trying to narrow down that list of possibilities. And so by the time we're done with the history, maybe the 100 possibilities is down to 8. And then we examine you. We look for signs of those 8 diseases and see if they're there, or see what fits and what doesn't. And so finally, after history and exam, we form what is called our clinical impression. It's what we think is going on. And that's the point. After we get to a clinical impression, that's when we're supposed to test. And this is true for any illness, not just Lyme disease. Because tests really aren't meant to just cast your line in the water and see what fish you catch. Tests are meant to confirm our diagnosis. And so when we cast the line into the water, we're only going for trout. We aren't going to catch the salmon, or we don't care about the sunnies. And so that's how we're supposed to use testing. And so in Lyme disease, when we use testing, we're just trying to confirm our clinical suspicion. And the tests that we use in Lyme disease are Lyme serologies. And that's a bummer that the red doesn't show up very well. Now, the serology is a problem, and because it's not really a good measure of infection. Typically, when you get ill, especially with a bacteria, we like to see the bacteria in your tissues, or we like to be able to culture the bacteria. And so, for instance, Borrelia burgdorferi, which is the Lyme bacteria, it's not easily seen in the tissues. It takes a special kind of stain, a silver stain. And because there are very few organisms to see and they're really scattered about, it's very easy to miss. The other problem is, okay, we can't see it, well, why don't we culture it? Well, this bug is very picky, and so it will only live in certain types of conditions. You have to add special things to make the bacteria grow. It's a very slow grower, and typically, if I get a culture for a urine culture, I'll usually, know in 48 hours, the lab will tell me, yep, you've got growth, it's, E. coli, it's this type, and this antibiotic kills it. In Lyme disease, labs, if they really want to be good about it, they'll hold on to those plates for 2 months, 4 months, 9 months. Well, most labs, they're not going to hold on to plates like that. And so they don't bother. It's very difficult to find a lab who's really going to culture you for Lyme. And so if we can't find the bug that way to confirm our clinical suspicion, what other tests can we use? Well, one thing we can do is we can say, well, does there seem to be evidence that the immune system is fighting the Lyme disease? And if there is evidence of that, we'll say, well, okay, that should confirm the diagnosis. But then if we're doing that, if we're looking at the immune system, that type of evidence we would say is indirect, because we aren't actually seeing or culturing the bacteria. We're just looking at a secondary response. Now, more biology for you guys. Our immune system has 2 parts, if you think of it simplistically. Now, the first part is the innate immune response. And that is something that's there right from the get-go. Some foreign bacteria gets in you and certain cells are activated and they kill it. Done. The acquired response is a bit different. First, your body has to be exposed to a new material that it calls foreign, so like a bacteria, a virus, a parasite. It has to kind of process that foreigner, and then what it does, it takes that information and it finally protects us. And the way it protects us is via antibodies. And so the acquired immune system makes antibodies. So antibodies themselves are proteins. They're in our blood, and so when and they're made by white blood cells. Now, antibodies are specific for individual foreign substances. So every foreign thing, every little piece of that bacteria is called an antigen. So antibodies kill antigens. So when we get in a bacterial infection, our body recognizes the invader. It tells the white blood cells to make antibodies. The antibodies attach to the foreign antigen and kill it. Now, because it takes some time to process that information and get it to the white blood cells and then make antibodies, it takes weeks for you to develop that response. And so there are 2 main types of antibodies that are involved when you have a Lyme disease. The first antibody that we talk about is IgM. And I like to think of it as if your body is called 911, and IgM is that first responder, kind of the jack of all trades. IgM is a very big molecule. It's got 5 arms, so it can catch a lot of things. That's good. The downside is sometimes it catches things it shouldn't. That's not so great. And so sometimes doctors will tell you that an IgM Western blot is not specific, or it could be a false positive. And that is true. False positives are more of a problem when you're looking at IgM tests than IgG tests. But really, IgM we should be glad to have it. But IgG is the one that really does the work. It will come in, it's slower to form, and it's going to really kind of do mop-up. It's going to get the majority of the bacteria, and it's going to stay around for a long time. And that's what helps give our immune system kind of a memory. Now what's sad is that the memory function of IgG in Lyme disease doesn't work very well. And the reason for that is the bacteria has so many different proteins on its outer surface that the infection you get in one year, the bug might look one way to your immune system. And then if you pick up another infection a couple years down the road, if it's a slightly different form of the bacteria, your immune system won't recognize it. And that's why when we tell people, just because you had Lyme once, you're not protected from getting it again. And that's one of the flaws with our immune response. Oh, darn. It's a lovely shade of purple, and it has 2 arms to it. So just envision that. You gotta roll with it. Now, think of this as the bacteria, Borrelia burgdorferi, and on the outer surface are these different proteins, which we call outer surface proteins. If you're reading things about Lyme, you'll sometimes see them abbreviated as OSP, like OSP-A, which simply means outer surface protein A. This was a very creative group of scientists, and so we have outer surface protein A and B and C and down the line until they finally got smart and they started giving them other names. They named them based on their weight, which was equally original. But so you can see there are different pieces that look different. And they look different to our immune system. So if we're having an immune response, we're going to get different antibodies. I don't suppose there's any way to kill that light rod. Or I should say to turn it on. But so if you make IgM antibodies, they'll come down and attach. And maybe you'll get some IgGs early, and they'll attach to a different piece of the bacteria. And the same type of antibody always attaches to the same type of outer surface protein. So if you have blue attaching to the green triangle, thank you, then you'll get blue attaching to this green triangle over there.
Look at that.
Asking. Thank you very much. So when we're trying to measure, is the immune system reacting to Lyme disease? Does this patient have Lyme? What we're going to do is measure antibody levels, because antibody levels would be the sign that the immune system is reacting. We measure it on your blood, and when we draw your blood, we spin it down and we get a part that's called serum. And antibodies are in your serum, and that's where the term serology comes from. But you can just think of it, it's a blood test. You can also actually check antibodies in other places as well. So like your spinal fluid, joint fluid. Now, these are the 2 serology tests that we're concerned about, and we're going to talk about each one in detail. The ELISA test is that first test that you get. Sometimes people call it a screening test, but it's not really a screening test, because screening tests we give to healthy people. And you're not healthy if you're getting a Lyme test. You're sick. Maybe you don't have Lyme, but you've got something. But this is the first test that we do, and they take that bacteria and they break it apart. And that's called a whole cell sonicated. So they've taken the whole cell, they've broken it into pieces. Then they got fancy and they attach an enzyme to each of those different antigens, each of those different pieces. They put an enzyme in there that changes color, and changes color if your antibodies attach. So they take the enzyme and the antigen combined, and they embed them on the test surface. It looks something like this. So they take the bacteria, they break it up, and they put the test in a dish of some sort. Usually it's a little micro well. And it's hard to see, but I attached little blue enzymes here. All of these guys have blue enzymes. And so they're sitting there. The next thing we do is we take your blood sample and we dump it in, right into that dish. If you've got antibodies that attach to those antigens, that enzyme turns color, and we can measure that. And what they actually do is, if you do have a color change, well, they know you have antibodies, so then they dilute your sample at a 1:2 ratio or 1:1, so it's half as strong. And they check again. Oh, we still see color change, and they keep doing that. And they can report it as a dilution factor, or what they can do is they know what the average healthy person has, and so that they do, if you have 3 standard deviations, it gets a little mathy. But basically they have cutoffs, and if you have more antibodies than what the cutoff says you should have, then you would be positive on your ELISA test. And so in our cartoon, we'd see that we've got the blue, no antibody attached here, so it stayed blue. And you have to trust me that this antibody attached and turned that orange. So that's how that works. Now the difficulty with the ELISA test is antigenic variation. Fancy term. That bacteria and all those outer surface proteins, each protein, like each triangle up there, could be 6 different colors. And the bacteria will cycle through that. And then each circle could be polka dotted or paisley. And so it'll cycle through that. And so if it's changing all of its different antigens, it's very hard for your immune system to keep up. But also, the tests use a very specific form of Borrelia to get the antigens that are put in the bottom of that plate. And that usually is B31. It's a great bacterial form because it grows. Of all the Borrelia, it grows nicely. So they can make lots of it. The downside is, if that's not the kind of Borrelia, if that's not the type of Lyme germ that you have, you might never test positive on that test and still have Lyme disease. And so the changing antigens is a problem. And someone tried to get around it, build the better mousetrap. Yeah.
Is that like pets will, dogs will come more common on a Lyme test than people will?
I don't know why. You're right that pets seem to have more positives than people. I don't know why that is. My own dog, though, had been vaccinated for Lyme, and she got it and was negative on that ELISA that the vet did, but positive on Western blots. And positive not from vaccines. So I don't have a great answer for why pets are different. But they tried to get around that idea of the changing antigens. And so what they did is they looked at this particular protein because there are parts of the protein that never change. And so they called those parts invariable regions because they never vary. And they took region number 6 and they made a synthetic protein. And that is what they use in the C6. So you can see where the 6 comes from. ELISA. Now the difficulty then is when they're looking at this test, they only look for antibodies to that invariable region. They don't care if you have any other antibodies. They're not even looking for them. And so otherwise it's like the standard ELISAs. So they put the thing in the dish, and they attach the colored enzyme, and they dump in your blood, but now they're only finding green antibodies. If you have red or orange or yellow, it's not going to show up on that test. If you don't have any greens, though, you're negative. And so the problem with this C6 ELISA is it too misses a lot of patients with Lyme.
Is there any advantage to having tests, like say a spinal tap versus a regular blood test?
Oh, absolutely get a blood test first.
But if you, I've already had several blood tests, but would there be an advantage to getting a spinal tap?
Not for that reason. You could, sometimes they'll do a PCR testing on spinal fluid, but you know, the sensitivity of that is low, about 20 to 30%. So, and we'll talk about sensitivity in just a minute. But so the bottom line is, I would not have you rush to get a spinal tap to try to prove that you have Lyme disease. Because if you're negative in your blood, it's less likely to be positive on the spinal tap. Of course, you know, there's always exceptions, but a good Lyme treating physician should be able to diagnose you without the test. Let's go back for a second. When we do Western blots, we separate out, we look for IgMs on one test and IgGs on another. The ELISAs look for both at the same time. And their sensitivity is about as good as the ELISA, which means it's about 70%. Not that great. But they're very specific. So if your Western blot is positive for Lyme disease, you got Lyme disease. I mean, you just do. The things that lab hate about Western blots is they're difficult to perform. You get different results on the same specimen, same from different labs. And so what many labs have done, if you go to your average doctor's lab, they aren't going to do their own Western blots. They buy a test kit. Test kits need to be licensed by the FDA. And whoever is manufacturing the test kit gets it licensed, and then they can sell it to whoever wants to buy it. Specialty clinics exist, kind of like IGenics or MDL. A lot of physicians in the East use MDL. And they make their own Western blots. They do not sell a Western blot kit to other labs, which is why your blood goes to them. Specialty labs are not licensed. Their tests are not licensed. Specialty labs are certified, just like every doctor's lab. They have to prove that they're good at what they do. And the reason I point that out to you is sometimes doctors will say, oh, IGenics isn't FDA licensed. Well, it's not supposed to be FDA licensed, but it's CLIA certified. And so sometimes doctors don't know the right terminology about the test credentials.
You said CLIA certified, what does that
CLIA is, it's one of the governmental agencies that you have to have meet certain benchmarks. And there, if you do, then you can, for instance, take care of Medicare and Medicaid patients, and the government will pay you for your service.
That's
CLIA. And like for IGenics, they always do well on their recertification, and they're also certified by the state of New York and the state of California. So how do you do a Western blot? What is it that makes everyone hate it so? Well, they take that bacteria and they break it up, and now instead of putting it at the bottom of a plate, they put it in a gel, kind of like Jell-O. And they attach an electrical current to that Jell-O. And what that does is the current separates the different pieces based on their weight. So the little pieces of the bacteria travel very far in the current. The heavier pieces don't move as much. Once they've got everything nicely separated out, they put basically a filter paper on top of it, and they kind of blot, just like you might blot with your Scott towel. And then they've got the antigens on that towel or filter paper, and they put in your specimen. If you have antibodies in your blood, they're going to attach to where the antigens are. And if you have enough antibodies attaching, you'll get a line wherever that antigen is. And then what happens is when there's a line, the tech will look at the whole gel. They'll look up and down at that filter paper, and they'll see where the lines are and how intense what they are. And I'm going to show you that because it's hard to visualize. So here's a Western blot, and these are the different weights of line antigens. And this was probably a control, meaning this was where everything was going to turn positive. But if you come over here to, column 3, this was somebody's blood. So they have positive at band 18, and they are very strongly positive at 31 and 34. And here they're positive at 39, and it's kind of faint, but it looks like there might be something here at 41. And so the technician in the lab would just kind of move up that column and note every band and then how strong they were. And I am not at all trained in that, but clearly this would have to be a 4. If your scale is 0 to 4, I think black is going to be a 4, and clear is a 0, and between that is all murky to me. But I would trust the word of whoever read it. And if you think about the specialty labs, they do a lot of Western blots, and so they read them, and so their texts get very good. They know what a 2 looks like versus a 3, whereas for me, it would be a guess. Now, there are at least 18 different antigens that are on those blots, and so you could get 18 different bands. There are many different ways to interpret a Western blot. Everyone, especially physicians, loves that CDC definition. They all glom onto it. But there are other ways, and there are other ways that are much more sensitive. And so if you were reading some of the journals after the CDC picked their criteria in 1994, there was discussion among the microbiologists about, well, gosh, if you added this band in, it would be much more sensitive. Or they were trying to make the case that if we only do by CDC criteria, many people would get misdiagnosed. They would be missed. And the CDC, for its part, said, well, guys, you're not supposed to be using our criteria to take care of the sick people who come in and need treatment. We're just trying to set up this special group of patients that we can follow over time. And so we can figure out which treatment works best. And so we've got to make sure that no one gets in our surveillance group who doesn't belong. And so that's why they made their criteria very strict. And they tried to reassure everybody that it's okay because you're not supposed to use it for all the people out in the greater country. Unfortunately, what happened is that everyone uses it to be diagnosed or not diagnosed. But so for the CDC, if you're looking at IgM, those are the tests they really only want physicians to pay attention to in the first 4 weeks of your illness. Now, in the last year or two, Dr. Steer did some studies, and he found that some of his patients didn't have an IgM response until week 6. So then he was starting to stretch it a little bit. But they really say that it's really in the first 4 to 6 weeks. They would not believe a positive IgM response if you've been sick for a year. I would believe it, but they won't. But if you've been sick for a month, then they think that you should have at least 5 of those antigens or antibodies. And they only look at 10. Now what's interesting is Borrelia burgdorferi, there are some antigens on it that are what we call specific. And they're these guys. And what makes it crazy is this. All the circles came down to what are the non-specific antigens or antibodies. So a person could have 4 specific antibodies and nothing else, and they would be negative by CDC criteria. Somebody else gets to dance into the room, and they've got 5 non-specific ones, and they're Lyme disease. That doesn't make any sense. And people protested that because that isn't very logical. These 10 were picked based on a statistical analysis of a certain set of patients with Lyme disease, and most of the patients had arthritis. And so that's becoming a problem that we haven't been able to shake. So I said certain things are specific to Borrelia burgdorferi. What does that mean? Well, sometimes those antigens, those different pieces, they can look like very similar to other pieces from other bacteria. Sometimes they even look like pieces of us. And an antibody, once in a while, will get confused, and it will react to both things, or 3 things. So sometimes antibodies react to things they shouldn't. Antibodies that do that are nonspecific. Antibodies that only react to a piece of Borrelia burgdorferi, we would say are specific. And so if you think about it, I would think it's much more important to have specific antibodies, even if I only have 3, than to have 5 nonspecific. Because you could maybe have mono and have a positive lung test from mono. And so that is a problem with Western blots, one of many. Everyone needs to understand the concept of what's a sensitive test. A sensitive test is one that finds everybody who's got a disease. They try not to miss anybody. And so a sensitive test will find most of the positives and will have very few false negatives. So very rarely would a sensitive test tell you you don't have the disease when you do. The difficulty with a sensitive test is that it sometimes tells people they have the disease when they don't. The flip side of that is a specific test. A specific test wants to find people who only have the disease. It only wants to find people with the disease. It really never wants to say someone has the disease when they doesn't. And so a specific test will have very few false positives. So all the positives on a specific test are real. The downside is it has a lot of false negatives. People have the illness, but the test says that they don't. One way to, in your mind, to think about the difference between the two is imagine all of us were out in the hallway and you were guarding the door and you were told to quickly let in everyone that has blue eyes. And so you're letting them come in, and maybe a few green-eyed people sneak in and a couple grays, but you kept all the brown-eyed people out in the hall, and so you did a good job. But we weren't happy with your skills, and so we gave you a new task, and everyone went back out into the hallway, and now we tell you to be more specific. Only let in people with blue eyes. Well, what happens? You are good at what you do, and this room is filled with one gray-eyed person and everyone else has blue eyes. Bummer is, there's a lot of blue-eyed people that didn't get into the room because you couldn't tell, and so you decided to leave them out. That is being a specific test. And so when you're a patient, you want a sensitive test, because to not get diagnosed with Lyme disease has really big consequences. If you're an epidemiologist, if you're someone studying Lyme disease, you want a specific test, because you don't want to waste your energy studying someone who doesn't have Lyme. And so there's kind of a cross purpose of how we're using these tests. One way to think about it is it's a teeter-totter. because these tests vary adversely. So if the sensitivity goes up, the specificity of the test has to go down. Or if we decide, well, we want a more specific test, then the downside is that the sensitivity is going to drop. We don't have a test that sits up here at 95 and 95. That would be the ideal test. The only thing I can think of that might even come close to an ideal test would be an autopsy. If we change the cutoffs, then that's how we can make sensitivity go up, or we can make specificity go up. So we could change the cutoffs for the Western blots, or the C6, or any of those tests. Now, I mentioned to you the C6, they were hoping that it was going to be so good and so sensitive that they could get away with doing Western blots and get away from doing what they called a two-tier. And so the CDC did this study, and they specifically wanted to see how the C6 did. Well, here's how it did. Overall, for acute Lyme disease, like right when you come in with your rash, it was only 45% sensitive. So you could flip a coin and be a little bit more accurate. And that's why we tell doctors, don't test when the rash is there, because the test is more likely to be wrong than right. And what's kind of sad is that for the people who don't have the rash, which in Minnesota and Wisconsin, I think that there's a high number of patients who never had the rash. What physicians are encouraged to do is, if it sounds like someone has Lyme disease, get a blood test, and if it's negative, wait a couple weeks and get another blood test. And that second test is called the convalescent. And the thought is that if your immune system is working, even if you don't have the antibodies here, in a couple of weeks' time, if you really have Lyme disease, you'll have the antibodies. Bummer, because it was only right 70% of the time. So that means 30% of the time, it was telling people they didn't have Lyme when they did. Well, neurologic Lyme fared even worse, because if you had early neurologic disease, like a Bell's palsy or meningitis, the test only found 60% of the patients. If you had late Lyme disease, which is the encephalopathy, the trouble thinking, maybe you have foot drop or the numbness, tingling, the test only found 73%. Now contrast it to how it did with arthritis, 94%. That's why they think the test is so great. The subjects that were used to develop the C6 had arthritis. And so arthritis patients look great on this test. The rest of us, we don't look so hot. And the reason that sensitivity is poor is because, believe it or not, the invariable region varies. And it can vary by up to almost 20%. And so they thought that they had something that was never changing, and it turns out it does change. And it's different from species to species and from strain to strain. The C6 was actually based on people who had arthritis from a European form of Borrelia. We don't have that form in the U.S. So why they thought to make that test here defies logic. I think they really did think it was going to be the same no matter what bacteria you had. Someone else recently repeated, and they made more C6s based on different types of the Borrelia, and they found that if you make a C6 based on Borrelia burgdorferi, it has a higher sensitivity for U.S. patients. And that makes sense, because that's the bacteria we have. And so the C6 is not ever going to replace the two-tier testing, but Dr. Wormser likes to write a lot about the C6. And so there's a lot of articles on it, but it's still a lousy test. And the Western blot is no better. If we look up here, What this study was doing is they got a bunch of specimens from the CDC and this other provider of specimens, and they were told what the Western blot results should be. And those reference labs used the Blot kit to figure out who was a positive test and who was negative. And so these researchers took those very same samples and they did Blot, Western blots, and they only agreed with the reference lab 85% of the time, and down here for IgM, they only agreed 62% of the time. So same test, same specimen, different labs, and wildly different results. It really doesn't inspire confidence. And then, to make it matters worse, and which you might not be able to see, oh, I guess she's up there. They also use some different test kits, same samples in this same researcher's lab, and look at that IgM. The sensitivity ranged from 62 to 85. How could you ever believe the results coming out of that lab? And it's not because the lab techs are bad, it's because the test kits are bad. And so even if your blood goes to Mayo Clinic, they're using a test kit. And so there's nothing special about getting a Western blot for a Mayo. Although they've developed a scanner so they can read the lousy results faster, they really don't offer much in the way of improved performance. Yeah.
What type of training do the lab techs have? What is their background?
Well, they're medical technologists, so they usually have a college degree. Now, there are some non-med techs. They have a different title. But, you know, it's not that the techs aren't trained. It's just that it's a difficult test. I know someone who used to do Western blots, not for Lyme disease, but just the technique. And she told me it takes a lot of finesse to to get the current to separate things out well enough so you can read your blot. And so she said it made perfect sense to her why specialty labs would be better at it, because they're playing with it all the time. And plus the specialty labs don't just use one form of the bacteria. They use several different strains. So they've got a mix of antigens. They're more likely to have something that your body is going to react to. So we're supposed to first do the ELISA, and then if your test is positive, you're supposed to have a Western blot. If your test is negative, you're done. You don't have Lyme disease. Well, we know what the ELISAs, how good they are, so that's really not probably the way to do it. And so when we do first the ELISA and then the Western blots on only the positives, what we do is we improve our specificity. We know that the people who test positive on both tests, they've got Lyme disease. But the trouble is to get that specificity, we really dropped our sensitivity. For instance, in late Lyme, the C6 was 73% sensitive. And the Western blot, IgG, for late neurologic Lyme disease is about 72% sensitive. Since we do one after the other, you multiply those two together, and overall, the sensitivity is only 53%. Flip a coin. Another way to think of this, it is this. If I started with 100 patients, all of them have Lyme disease. We know. They're all represented by a capital D for disease. I do that C6 ELISA, and 27 of those patients disappear. They're gone. They were test negative. Now I do my Western blot, and I've made a total of 47 patients disappear. They still have Lyme disease, and they're still sick, but they can get pushed to the side because the test is negative. Besides the test being bad. There are other reasons that people test negative, and one is because you've got so much of that bacteria in your body, and your immune system is pumping out antibodies, but as soon as you make an antibody, it gloms on to one of those antigens, one of those pieces. And so you don't have any free antibodies in your blood. So when they test you, there's nothing that can react with the antigens because all of your antibodies are already busy. So that we would say are immune complexes, the antibody and the antigen combined together. There are actually methods to separate them and then do serology, and research labs have done that, but it's not something that's done in the everyday lab. And so immune complexes will get in the way. There's also something called seronegative Lyme. What that is this. If you have got the Borrelia in your bloodstream or in your body, and you're starting to make antibodies, but you're just getting started, and now you get antibiotics. And you get enough antibiotics to clear most of the infection. Most of the antigens are taken from your body. What happens is your immune system gets turned off. It doesn't see anything to react to anymore, so it stops reacting. But the few bacteria that survive that now can go into hiding and then start to replicate, and you'll have infection, but always a permanently negative test. That's been shown time and time again in the trials of early Lyme disease. Now the move has been afoot to try to pretend like that isn't a real thing, but it is a real thing, and we see it in other diseases. When a woman is pregnant, if she's what is called Rh negative, that means she doesn't have a certain antigen on her cell type. And if she happens to be pregnant with a baby that's Rh positive, if she gets exposed to any of that blood when the baby is born, she might then start making antibodies to Rh. Won't hurt that baby because it's already born. But then the next pregnancy comes along, and if it's an Rh positive baby, mom's antibodies will actually kill that baby in utero. And that used to happen until they invented Rogam. And what Rogam is it's antibodies for Rh. And so when an Rh negative mom delivers an Rh positive baby nowadays, she gets a shot of Rogam. Those antibodies clear all of the baby antigen away from the mom's bloodstream before her immune response can ever get turned on. And so we know, in a sense, we keep making her a seronegative mom. And so that concept is the same concept in seronegative Lyme disease. People would like to make the concept go away, but it's not going away, it's real. And so Dr. David Volkman, who actually spoke at the infectious disease review hearing, he was one of the first researchers to understand that concept of seronegative Lyme. And he'll say that there are people walking around with Lyme disease with zero bands. Zero bands. And so it really is something that we have to think about. So our serology, it's really very specific, but the sensitivity is so good. What that means to patients is that if you're a positive, you're great, you're good to go. We are not giving antibiotics inappropriately. The downside is that many people who need antibiotics don't get them. If we change the cutoffs, we could improve sensitivity, which would be great. More people who need antibiotics would get it. But the downside is we'd also be giving antibiotics to people who don't need them, and we don't want that because antibiotics, while very safe, they're not completely benign. People do get allergic reactions and they get C. diff colitis, and so we really only want to give the antibiotics to the people who need it. And so there's this constant interplay of what's the right thing to do? How should we be using these tests? Personally, I think we should let the epidemiologists keep their very strict definition. That's fine for what they do. And we should let the clinicians have a much more relaxed definition because that's what they need to do their job. And it's really summed up quite nicely. This is a quote from Paul Mead. He's a CDC epidemiologist. He does Lyme. And so what he says is a clinical diagnosis is made for treating an individual patient. And we want to consider all the details of your illness. But surveillance case definitions are really created for standardization. They're not really interested in caring for patients. So they exist for health officials, so they can compare things, numbers and distributions over space and time. And that makes sense. And so what the guys at the CDC over this change in the definition and the lab requirements. And at first I didn't tell them I was a doctor, but then ultimately I fessed up. And I said, so are you really essentially telling us that the Elisa is not a good test and it's getting in the way? Is that why we don't have to do it anymore? And he kind of stammered and came up with, oh no, it's that sometimes doctors lose lab results. Truly that was the answer. Dumbfounded, I was dumbfounded. Now, if we do all these tests, we do your serology, and I think you have Lyme, but your test is all negative. Ooh, what am I gonna do? Well, the first thing I'm gonna do is I've gotta go back to that big list of possibilities and really think, now, could this be diabetes? Could this be MS? Could this be anything here? And you're probably going to get a bunch of tests to tell me whether or not it is something on this list. So I do all those tests, and you've lost a lot of blood now and feeling even more tired, and they were all negative. So I'm stuck. But I'm not stuck. I should go back to my first impression, and then I haven't found anything else to explain your problems. That's when I can do an empiric treatment trial. I'll say, you know what? We're going to try something for Lyme disease and see what happens. If you get better, probably is Lyme disease. Now, some people will say, if you get better, it was a placebo effect. Well, better's better, so that's a good thing. But what I never do when I talk to people on the phone, I never tell them about Herxheimer reactions. So I say, just call me back in a week and tell me how the week went. And the reason I do that is if they call me back and they say, God, this last week was really bad, everything was worse. You really, what did you do? And it's usually, of course, I'm not prescribing, so I didn't do anything. But no one, since the patient didn't have it in their head that they were going to get worse, the fact that they did get worse tells me we're on the right track, because many people with Lyme get worse in that first week. So I've never heard of a placebo effect where we give a patient a pill and they expect to get worse. Patients, when we give them a pill, expect to get better. And so a negative placebo effect in Lyme is really good evidence that you are treating the Lyme infection. So to summarize this very long-winded talk, the tests are lousy, and this is the reasons why. They miss too many people. A same sample gets different results from different labs, so they're very unreliable. If you change the cutoffs to pick up more patients, we do create new problems. The bottom line is there's no shortcut. Physicians can't get away from sitting down and taking that detailed Lyme history and doing that exam. And patients can't get away from that, from giving their history and going through that exam. And so we want to encourage physicians to use their judgment, and all of us should be demanding research for better tests. Now, how much time? You've been such a great audience that there's a little bonus material. PCR testing, that's the fancy stuff they do on the crime shows. It's a DNA. They're looking for pieces of the bacteria's DNA. In the old days, they looked for one. Now they're getting really tricky. They use multiple probes is what they call them. And there's even something called a nested probe. And so they're going in and they're going to test your blood or your spinal fluid, your joint fluid, and they can even do PCR on tissue. And the best tissue to do it on is from a skin biopsy. The trouble with PCR is it's costly. Not a lot of labs offer it, and quality control has to be very good at these labs because it's easy to get false positives because DNA from other sources can get in there. But the sensitivity is bad. It's like 30%. And so that's why I wouldn't have you get a spinal tap. I wouldn't, because you could have Lyme disease and only 30% of the time will your spinal tap be positive. Spinal taps are more likely to be positive in people who have European Lyme because their neurologic Lyme causes a lot of inflammation early on. But our U.S. Lyme is not like that. The other interesting thing about PCR tests is it's easy to get joint fluid, and so people with their big arthritic knee come in and they get that fluid drawn off and they get a PCR and it's negative. Same person's come back and maybe they have to have some arthroscopic surgery and the surgeon even snags a piece of that tissue and they PCR test that and it's positive. Now that probably is because the bacteria can live inside cells and it can live inside the cells that line our joints. And so that's why even if the fluid is negative, if the bacteria is in the tissue cells themselves, the tissue can be positive. But I can tell you, it really confuses the heck out of the physicians, and most physicians would only get the joint fluid, and if you're negative, they wouldn't ever go get that extra sample. Some labs do culture, but they're few and far between. It's usually research labs, and it's because culture is very insensitive. Down a culture of someone's spinal fluid, when they had Lyme meningitis, only 2 to 5% of the people had a positive culture. If you are going to culture, sometimes they'll draw off like what we'd say is 25 milliliters of blood, so that's called a high volume sample. And they have special ways of handling that. But again, the labs hate hanging on to it for 8 months. If you're going to do this, someone's got an erythema migrans and for some reason you don't trust your eyes, then you want to get a biopsy from what we call the leading edge. As the rash spreads out, you want to get it from that last edge. And you can culture joint fluid. Other things that we can do to try to diagnose Lyme, some people do what we call imaging studies. The old term was x-ray studies, but we're not always x-raying you anymore. Sometimes we're making magnets look at you, which is the magnetic resonance imaging, MRIs. MRIs cannot distinguish Lyme disease from other illnesses. So really, the use of an MRI in a patient with Lyme disease is to make sure they don't have a brain tumor or a big fungus ball. I mean, it's to rule out other things. And it's very important to know that there's no way on MRI to distinguish MS from Lyme disease. And that's really important because I've heard of a lot of patients who had negative spinal taps for MS, but they were told because of their MRI that they had MS, and they could have just as well had Lyme disease or something else. Mm-hmm.
What if if you had an MRI of your brain and then they thought at the time that you had MS and then proved it not to be, then would that signal that it's possibly Lyme if something showed up on the MRI?
You can have lots of different findings on an MRI and when you have Lyme disease. But there's nothing about the MRI that is specific, where we can say, oh, if we see 5 white little dots here in your left frontal lobe, that's Lyme disease. There's no pattern on the MRI.
But so when I went in and they did an MRI and then they told me I had MS,
Mm-hmm.
and then they did the spinal tap and everything, and then they told me I don't have MS, and I said, well, what was that spot? And then they just kind of went, I don't
Right.
So, but,
Could that spot be Lyme
could or could
disease?
not
Sure, it could be.
oh, okay.
Yes, it could be. And in fact, they used to think that they could use MRIs. And so they would do a before and after. They would give your MRIs. Oh, you got Lyme disease. Treat you for Lyme disease. Except those people, by the way, had culture positive. So they really did have Lyme disease. And some of those people, the MRI actually improved, but not everyone did. And so it didn't correlate with how the patient was doing. And so it's really not useful for Lyme disease. The SPECT scan, which is a test that actually looks either at blood flow in your brain or even metabolism in your brain, that is, again, it can't tell you that you have Lyme disease, but it can certainly tell you that you have abnormalities that are consistent with Lyme disease. And the abnormalities that they see is that the blood flow is decreased and it's patchy. I guess in some areas it's more likely to be altered than in others, but I don't really know all of those details. The one nice thing about a SPECT scan is if they figure out that you have Lyme disease and you have a pre-treatment SPECT scan, they can actually, as you go through treatment, your SPECT scan will improve. So your blood flow to your brain improves. 1 second, Kim. And so that is one way to follow. The bummer is most insurance companies do not pay for SPECT scans and they're very pricey. Yeah, Kim?
I'm just wondering if a SPECT scan would find MS, or if it is more specific.
No, it's not a way to diagnose MS either. MS is actually a clinical diagnosis. We look for oligoclonal bands in your spinal fluid, and we do MRIs, but you have to put it together with that history. And they did a study in England where they took MRI scans of people that they thought had MS based on that's how the radiologist interpreted it. And they had other radiologists look at those same scans and they didn't come up with a diagnosis of MS. So it kind of proved that MRI diagnosis of MS is, it's a guess. And that radiologists disagreed.
What does ALS tie in with
Well, ALS involves what we call the anterior horn cells in your spinal cord. So there are these big motor cells that move muscles. So that you might get some abnormalities if you did an MRI along the spinal cord, but you could have a totally normal MRI of your head. And you could have ALS and have a totally normal MRI of your spinal cord.
So that's connected with the
Isn't it interesting that the neurologic syndromes, ALS, MS, and Parkinson's, all clinical diagnoses, and all diagnoses that I have seen wrongly applied to patients in Minnesota and Wisconsin. And I think it's because we have a funny strain of the Lyme bacteria that has a lot of neurologic problems associated with it.
Do you know if serous cavities in the spine mean anything with Lyme?
Pardon me?
Is it
A
serous?
syrinx? That's different.
Okay, so
That is, but yeah, that is kind of like a cavity that can expand and it pushes the normal contents of your spinal cord, it compresses them. So that's an important thing to get taken care of. And that's the other thing, we don't want to miss something like a syrinx and call it Lyme. And that's why if your tests for Lyme are negative, it would, your doctor has to really start looking for other things before they settle on a Lyme diagnosis.
Excuse me. I've had conflicting information about doing an MRI for your lymph nodes. Like if they're excessively swollen, we could have, he was thinking of doing that test to rule out Lyme's disease. But then a second opinion said, no, that's not really going to happen.
Well, you can do an MRI and you would see the swollen lymph glands, but your lymph glands can be swollen from all sorts of other non-Lyme things. So, by the way, though, I have seen a lot of patients with who have had the lymph nodes in the mediastinum are enlarged. And so you can see that in Lyme disease, but that would not be a way to diagnose it. You'd have to, that would just be one piece of a big puzzle. Mm-hmm.
If you can see the Lyme bacteria under a microscope, why can't you just send in a blood sample to a laboratory and have them identify whether you have it or you don't have it in your blood?
Well, that's a great question, and it's not as easy. So when you go to YouTube and people are showing you those Lyme bacteria, I'm not sold. Because spirochetes, they look similar. We have spirochetes in our mouth. They're just a different, if you think of a family of bacteria, and the spirochete family, we've got Borrelia burgdorferi here, we've got Borrelia garinii here, and Borrelia, it starts with an Ephesii here, and then over here we've got Treponema pallidum. I said that wrong, I'm sure I did. We've got the syphilis spirochete. Then we have these spirochetes that live in our mouth and cause dental plaques. And so if you look in the blood, you don't really know, unless you're very good, what kind of spirochete that is. The other thing is that the Lyme spirochete does not spend much time in the blood. It wants out. It only sees the blood as a means to get to other places. It has special proteins that it can attach to that blood vessel wall, hang on, and get through it. And so I don't think it's likely that most people are going to be able to do that, even a pathologist. Because one, they don't typically do silver staining, which is the staining technique on blood. And so it's not quite the easy process that people on YouTube will make it out to be. Mm-hmm.
It's some $300 for a test in a lab in Florida that says you're wrong. I threw a lot of money away.
Well, that's the central, is that the central lab of Florida, or the it used to be the Bowen lab?
Yes.
You know, people look at things differently. I'm just telling you what I know. And it's tough. I wish that we just had a great test and we didn't have to spend our money out of pocket. But that's kind of, I'll just stop right there on that one. I wanted to show you a picture of the SPECT scan. It's not as, oh shoot. Here's a normal brain, and there's a lot of kind of orange and yellowish colors. These are the ventricles of the brain, which are areas where the blood flow isn't so great, and it comes in blues and purples. Here's someone with Lyme before they got treated. A lot more blue and purple, and a lot less of that very bright orange. Then this person got treated, and they're starting to see more blood flow, so they're getting more of that orange back, a little less of the dark color. So that's, when they do a SPECT scan, they not only look with their eyes, but they've got very, computers that are measuring the optical, qualities of each of these little pixels, and they come up with a sum for your blood flow. And so when they follow SPECT scans, there's a number attached to your SPECT scan. Well, that's the end of the bonus material. So I also want to put a plug in. The legislative committee has worked really hard to make it as easy as possible for you to contact your rep and senator. There's a letter already kind of written out, kind of a fill-in-the-blank letter for you to use. And we just have to get it done, because when you talk to the legislators, they say the thing that motivates them the most, more than any lobbyist or any piece of material that we can produce, is a phone call or an email, or if people really sit down to write a letter. I'm not expecting you to write a letter, but all you have to do is a couple clicks, and you can have an email off to your senator and rep. And if you're having trouble knowing who your senator and rep are, we can even help you with that, because we really need these letters to go. And if you are sick with Lyme and you have a cousin up in Detroit Lakes, have your cousin contact their person and just say, hey, I have a sick family member with Lyme disease, please support our bill. Doesn't have to be long, but we have to get emails flowing, so please, everyone, do that. Were there other questions?
Can you talk about pulse line? So I've gone through my line treatment, cured or pretty close. I've just become aware of CD57 and the immune strength test.
Okay. CD57. You know, I'm always very direct. I don't like the CD57. I don't think it's the be-all to end-all. And the reason is because you have to use not only LabCorp, but there are apparently certain LabCorp labs that are better at doing the test than others. So if you get a CD57 at the Elisa lab, your value won't match up with your LabCorp value. I think in some people, there does seem to be a correlation. Like when they're feeling well, their CD57 is normal. And when they're feeling lousy, their CD57 is low. But I've seen people who have been feeling lousy with a relatively normal CD57, and then when they start to get well, their CD57 falls. And so those are all red flags to me as a clinician, that I can only use a certain lab, that no one else can do the test right, and that it doesn't always correlate. Makes me think that maybe we're onto something, but that's not quite the right test.
Not the right test or not the right people conducting it?
I think it's both, because a good test should be able to be done in any standard lab. If you get your white blood cell count done, and then for some reason you go to clinic A, B, and C within the same hour, you're going to get results that are very, very close. That's a good test. When you get a different result from all sorts of different labs, which are good labs, then that's a bad test. It's not that all the labs are.
Okay.
Yeah, yes, sir.
Okay. This is a complicated question. In my case, my line really messed with my testosterone, and my bone pretty much almost disappeared. And I went off the ladder and just mutilated my ankle. Okay. Doctors figured out that it was from Lyme, as specialists and stuff like that. They gave me stuff to get the bones back together. My ankle got sort of better, but the basically we're running bone on bone now. And so they sent me to another specialist that I to see if I could get an ankle replacement, because they do have artificial ankles now that are pretty good. So his thing was, well, Tom, you're a great candidate for an ankle replacement. You can't have it because you have lines. And lines can live in your, even though you may think you're cured, they can live through very knowledgeable lines. Because what? And he says that it can be in your bone for 10 years. And when I put in the new ankle, he goes, there's a 70% chance that it will reject that ankle.
Oh.
So, how in the future, even though we may think we're rid of Lyme, how do we know if we really are?
You won't.
We don't.
And these are my personal opinion, but I think that we need to switch our thinking with regards to Lyme disease. I think that cure is always a great thing, but I think the model that works better for Lyme disease is similar to the model that we have for herpes. Now, there are many different herpes viruses, not just general herpes. There's the herpes virus that gives us a cold sore. Now, that virus, most of us, if we test, you will have antibodies for that virus. But many of us never get a cold sore. Well, we got the virus, and our immune system is so good, it keeps that virus at bay. Other people, if you stress them, it'll pop out, and they'll get their sore, and then it goes away. And then there are some people who have just recurrent sores all the time, and those are the people that you might give Valtrex to. Certainly, that's what they're doing when they talk about genital herpes, is that poor patient that always has one sore after another, you know, the commercials say daily bell checks. And I think that's how we're gonna think we should move to that model with Lyme disease. Some people get Lyme disease and they really do get cured, they get over it. But I think most people get Lyme disease, especially if it took a while to get diagnosed, that bug is so good at finding a way to live with us that all we can do is get our immune system to a place where it can keep the germ at bay. And then once in a while it's going to pop out when you're under extreme stress. And by the way, surgery really makes Lyme pop out. And so then there are those people who have such significant symptoms that they almost need a daily dose of something. And that's how I think of it. The more I look at this bug and read about it, it can live inside our cells, and a lot of antibiotics don't get inside cells. Our antibodies don't get inside our own cells. And so that's one way to escape it. It goes into other forms that fool our antibody. It can kind of lay dormant. Syphilis goes dormant for decades, and Lyme and syphilis are cousins. And a lot of the researchers know that Lyme does this. And so I think that the orthopedist you were working with was very smart, and you should actually try to get his note from that visit when he told you that. Because if he put that in his dictation, that's something you would want to say.
Yeah, I go back February 2nd, he says, well, since we can't give you a new ankle, we can fuse it. We'll give you an ankle fusion. So we go, and he says, I can do it in such a way. He's the guy that people watched CCO a couple months ago, and CCO TV had a big thing on him where he was the leading guy in the Twin Cities of all ankle replacements and stuff. And so that's what the guy got to see it. And he got to see when he was doing some work in Boston, and it was a fellow doctor that come down the line. And he goes, it wasn't for that doctor. I would laugh at you was saying it's Lyme. Because this doctor kept complaining that I think I got Lyme, and we just get, you know. And pretty soon after, I think he said his both knees and one hip completely deteriorated, the people started taking him serious, and that's when they figured out at that time, and I think that's when they kind of, you know, were doing the replacements anyway, and they rejected him.
Right.
And he goes, it's a way bigger problem than doctors have figured it is. If I was, you know, I would have never known, he said.
No, but, you know, maybe we should just go and infect enough doctors. No, I don't really believe that. I had
One more comment. Afterwards, I'd like to talk to you about something else that's kind of privileged information that I can tell you about.
Ooh, everyone else is good. Sure. Post-Lyme, I think post-Lyme syndrome is a tag that is basically said, you may leave my office now. And I say that because it's difficult. You know, patients are all over the map when they come in. Some people are very, very sick. Some people aren't so sick. We know that there are different strains of the bacteria have different levels or abilities to cause disease. So some strains of bacteria only cause the rash. They are never going to bother a neurologic system. Okay, so then if we put those kinds of patients in trials on Lyme treatment, they're always going to make the treatment look great because they were never going to get worse. And so there's so many things about Lyme disease that it's just impossible for us to know how any one patient is going to respond to therapy. But logically, if someone comes to me and they say, Betty, I'm tired and my joints hurt and my muscles twitch and God almighty, I forgot my multiplication tables and oh, my Lyme test is positive, I'm going to say, hey, sounds like Lyme disease to me. And if I treat them and they say, hey, Betty, I'm less tired, and I can add really well, but I still can't multiply by 9. And my joints don't hurt as much, but my knee does swell. I'm not going to say, boy, those symptoms no longer matter, which is kind of what post-Lyme does. They'll say, those symptoms don't mean that you're still infected. Well, they meant infection when you started, so they should still mean infection. I do want to say, though, that the immune system in Lyme disease is not understood. And a lot is happening. A lot of these inflammatory chemicals are really high during the infection. And it doesn't take many spirochetes to keep those chemicals, those cytokines churning. And the cytokines can do damage. And so one of the issues of treatment might be, okay, we've done all we can with antibiotics. Should we try a different approach? And that I'm okay with saying it that way. But what I don't like is the implication that your Lyme is done. Because we can never prove that your Lyme is done.
Treated you with severe symptoms, but
Right, now you're crazy. Yeah, that doesn't fit. Way in the back.
I was, when I was in Maloney, I was kind of told, I suggested that I might have Lyme because every symptom I've ever had matched perfectly. And the neurologist that I would see kind of, I don't want to say he snickered, but he did a up. So the diagnosis that I got when I left was that I had a viral or bacterial infection attacking my brain, but he thought it was gone. And because my symptoms were gone, but my symptoms aren't
Right.
gone. So, I'm just wondering, like, in a case like that, when you're leaving the office and they're saying that your symptoms are gone, they're prescribing you with like all these medications for your symptoms. I mean, is that like what they're saying when they're saying that this is the post-Lyme syndrome?
Well,
What are they just?
I think what they're saying in your case is different. They're acknowledging that you have symptoms, but they are not going to say that you have Lyme disease. So they'll say your symptoms were due to something else. Like I know a patient and she was told that, oh, you have Guillain-Barré, which is kind of this inflammatory nerve condition. Oh, but now your Guillain-Barré looks like you're getting better. But then a few months later, she was even worse than she had been at the start. So clearly she didn't have Guillain-Barré because it doesn't do that. And so the doctor didn't know, and so they wanted to give you some kind of answer, but they are very resistant to the diagnosis of Lyme disease. The neurologic community, they're good physicians, but when you read their literature on Lyme disease, they are very skeptical of Lyme. And I even, once I was writing a letter to the editor to the journal Neurology, which at the time the editor was the chief of neurology at Mayo Clinic, and he was just over my letter. It took like 5 months, and twice I had to go to what's the ombudsman, who's basically the referee, to get him to make the editor follow the rules. And so neurologists just have not been given good information, and they are a very analytical bunch. They don't fly by the seat of their pants very much. And so they would be more inclined to send you out the door with the diagnosis that you got, which is the unknown and improving bacterial infection, viral infection, than to tell you you have Lyme. And we know how bad the testing for neurologic Lyme is, and so they don't have any good tests to give you to prove that you have Lyme. And so your best bet, if you think you have Lyme, is to see a physician who really specializes in Lyme. Yes, Tom?
I just want to comment that you were here. I went to Mayo, I was twitching all over, couldn't talk. Some of you saw me, how sick I was.
Right, the one thing I'd like to caution people about is when you're dealing with physicians, and remember I am a physician, they have the upper hand because they control the chart, the entry into the chart. So if you push too hard, and you can sense it, it's like dealing with, you know, anyone else who you're trying to negotiate with. If you push them too hard, watch out, because women will end up with things like somatization disorder or conversion disorder. Guys are more likely to be diagnosed with chronic fatigue syndrome, which, by the way, is actually real because they found the virus for chronic fatigue. And so chronic fatigue patients used to be thought of by many as people who were mentally ill, and that the doctors treating them were quacks. And now, lo and behold, turns out chronic fatigue was an infection. And so Lyme disease, well, I think we'll eventually get there. But in the meantime, be careful, because once you get a mental health label, like somatization or conversion disorder, it is very hard to get other physicians to really pay attention to you and to see beyond that label. And so I do caution you, if you really feel like that resistance is building, find a way to diffuse and get out of there and don't go back. Because it really can be a problem. Especially now, medical records are electronic, they follow you wherever you go. In the old days, you didn't like a doctor's note, you could throw it away. Not so with electronic medical records, so don't push too hard against that wall. Network with people here. They can tell you a couple of neurologists, and they can certainly tell you Lyme doctors. And one more, maybe. Oh, you guys okay? Sure.
If you are eventually diagnosed as Lyme, but you've probably had it for 15 years plus, and your doctor wants, suggests doing a trial, like for me, my IgM was positive, but the IgG was negative. So he wants to do a trial treatment. But is there any advantage if you're not in a phase where you're manifesting any symptoms?
Oh, that's a great question. Because there's two parts of your question that are important. Some people are only IgM positive. Why would that be if they've been sick for a while? Because, I said how your immune system, that IgM is the first responder, and then it goes because IgG comes in and does the work. Well, it's because that bacteria has all those antigens that it's cycling. It's like it's got a closet full of coats. And it goes in and it pulls out a red coat, and it wears it around until we make antibodies to the red coat. So it slides that away and grabs the yellow. And it does that so much that by the time it comes back to the red coat, your body thinks that it's never seen the red coat before. And it starts over from square one with an IgM response. And so yes, patients with Lyme disease can have a constantly positive IgM, and it's not from a new bite, it's from that cold, it's from that same infection. So that's point number one. Point number two is really tricky, and I don't have a great answer. It's, do we treat someone who's feeling okay now but has Lyme disease? The things to consider are this. If you're doing all right with just as things are, life is good. And antibiotics and some of the other things we might give you can have some downsides. So if you're feeling good, what will treatment do for you? Well, in the short run, it might not do anything for you. So looking at it that way, I would say don't do anything until you become symptomatic. There's one kicker though, and it's the one that bothers me. Patients with Lyme can become demented. So they develop dementia. It looks a lot like Alzheimer's dementia. And in fact, there are pathology specimens from people diagnosed with Alzheimer's dementia that did indeed test positive for the DNA of Lyme. So then, did Lyme disease cause that dementia? And if Lyme disease can cause dementia, should we try to get on top of it before you start passing? I don't think that anyone has an answer for you yet. But I do worry because as people live longer, we're seeing more dementias. We don't usually separate. Basically, we often call things Alzheimer's when we should call them dementia, because there are many forms of dementia. And so if we're dumping everything into this Alzheimer's basket, and we're seeing that there are more and more cases of Alzheimer's, it makes me think that probably we should go into that basket and try to sort things out. Because some things are going to be Lyme. In the olden days before we knew about syphilis, some of the dementia was syphilis. Now we don't see so much of that anymore. But I think infections are going to be one potential cause of a dementia that looks like Alzheimer's. And so knowing that makes me a little bit nervous. But I think that's where you and your philosophy, are the most important thing.
But if you're saying that there really is no way to totally get it out of your system, then does it do any good to do a treatment when you're...
And you're asking such really good questions. Those are so thoughtful because I don't know. Because what if we really kind of help their immune system? Maybe it could really get things at them. Maybe if by doing that we would prevent long-term problems. But no one's ever done a study like that, so there's no correct answer. It would be a guess.
But it's not going to hurt you to do, other than I may feel worse, even though right now I'm feeling pretty good. Sometimes you feel like if you're feeling good, you need to nestle it.
Right. Right, don't break it. Don't fix it.
How long is it going to last? But it's not going to hurt anything other than I may feel rotten for a while doing the treatment. But
Well,
it's not going to...
No, I don't want to say that because antibiotics are serious medicines. So if you get an antibiotic and it ends up causing you to get a special kind of diarrhea, a diarrhea called C. difficile, that's a very nasty illness that once in a while people die from. So boy, wouldn't I feel bad if you took something that killed you when you were feeling well. And so that's a rare occurrence. But things are rare, that means they happen. Rare things do indeed happen from time to time. If you're the unfortunate person, dead is dead, or sicker is sicker. And so that I do take loss. Same like putting in the long arm catheters. Boy, there's risk there. And I want to make sure that the benefit outweighs the risk. And right now, it seems to me like I don't know where the teeter-totter's going for you. So maybe you should be level.
Can I draw an analogy between what you just said and your answer? Again, as you get older, more men die with prostate cancer from it.
Right.
So I'm not treating it even though my father died of it. So I shouldn't get treated. I mean, that's just the way it is. Things are good. I shouldn't worry about it, right?
No. If you have a family history of prostate cancer, then that's a different thing.
We're not getting tested here, but
Right.
I'm just saying, you live with it, right? I mean,
Right.
My
Well,
body's dealing with it, but if I get to be 90, who knows?
but the trick with prostate cancer that we're trying to figure out, because it is a similar analogy, is if we could figure out which prostate cancers are the bad ones and that are indeed going to kill the guy, we'd go after them. Well, right now we haven't figured that out. And that's probably part of the problem. So you can't start diving into treatment until you know kind of the downside of the treatment. We want to, you know, we don't want everyone diagnosed with Lyme. We only want people with Lyme diagnosed with Lyme. And that way, once we do that, then we can then make sure that each Lyme person gets the treatment that's going to meet their needs. And your Lyme